Chapter 18. Aseptic techniques can be applied in any clinical setting and are particularly important in situations involving surgery, intravenous lines, urinary catheters, and drains. The goals of aseptic technique are to protect the patient from infection and to prevent the spread of pathogens and/or harmful microorganisms, so clean, sanitize, and disinfect. The two classes of asepsis are surgical and medical. Medical imaging presents particular challenges due to equipment designs, the variety and nature of exams, and the mixed levels of staff expertise. Procedures requiring aseptic technique are biopsies, angiographic procedures, line placements, hysterosalpingography, where a thin catheter is inserted through the cervix into the uterus, and arthrography. Sources of infection are the skin, hair, nasopharynx, fomites, air, human error, and cross-contamination. Surgical asepsis facilitates protection against infection before, during, and after a surgical procedure by using sterile techniques. Medical asepsis, in contrast, can be defined as the removal of or destruction of infected material. A surgical medical imaging team consists of a chief surgeon, assisting surgeon, anesthesiologist, or certified registered nurse anesthetist, CRNA, operating room, OR nurse circulating, surgical technicians, surgery radiographic technologist, and OR support staff. The sterile field is a microorganism-free area that can receive sterile supplies. It is established using a sterile drape. It contains no viable microorganisms and can only receive clean and dry, unexpired, and unopened materials. The sterile corridor is an area between the patient drape and instrument table. A first step in using a sterile drape is to confirm that a package is sterile. If it appears to have been previously opened or the expiration date has passed, it is considered unsterile. When establishing a sterile field, first hold the drape with one hand at each corner. Slightly double fold the top edge to lift the cover and lay the drape on a clean, dry surface with the bottom farthest from the person who is establishing the field. Drop sterile contents gently onto the sterile field from about 6 inches above the field and at a slight angle. This helps ensure that the package wrapping does not touch the sterile field at any time. Do not reach across a sterile field. When pouring sterile fluids into a sterile basin, containers are considered sterile only on the inside. Verify a container's contents and expiration date. Pour the precise amount of solution required and avoid splashing the contents onto the sterile field. Pour contents at the edge of sterile field, about 1 to 2 inches above the sterile basin. Sterile trays must be opened prior to putting on sterile gloves. Sterile self-gloving technique involves first picking up the glove by its inside cuff with one hand. Start by gloving the dominant hand. Do not touch the glove wrapper with the bare hand. Slide the glove onto the opposite hand. Leave the cuff down. Next, using the partially gloved hand, slide the fingers into the outer side of the opposite glove cuff, then slide the hand into the glove and unroll the cuff. With the gloved hand, slide the fingers under the outer edge of the opposite cuff and unroll it gently, using the same technique. The inside of a glove can be touched with two or bare hands, but the outside of a glove can only be touched with the outside of another glove. When removing sterile gloves, begin with the non-dominate hand. To remove contaminated gloves aseptically, grasp the edge of the glove. Unroll the glove over the hand. Discard the first glove. With the ungloved bare hand, grasp the opposite glove cuff on its inside surface. Remove the glove by inverting it over the hand. Discard the second glove. When gloving while wearing a gown, keep your hands in your sleeves so that you do not touch the glove on the outside of the gown with your bare hands. Keep your hands above your waist and in front of you. Do not touch anything around you that is not sterile, including your face, mask, and hat. Surgical gloves are sized numerically, from 5 to 9 with half sizes available. A good tech procures 3 sizes for the surgeon in case the fit is imprecise. The technologist's responsibilities when images are performed to confirm chest or thoracostomy tube position and chest status include not snagging tubing on the X-ray equipment. The exterior assembly of the chest tubes must always remain lower than the patient's chest. Suction is not a tech's responsibility, but a nurse should be notified of atypical secretions. Lines may be inserted as high as the 4th and as low as the 8th intercostal space. Report drainage in excess of 100 milliliters per hour and any change from a serous fluid to a darker red-colored secretion. Chest tubes may be present because of atelectasis, which is partial or complete lung collapse, pneumothorax, which is an air accumulation in the space between the lung and the chest wall that also can collapse lungs, Hemothorax, where blood accumulates in the pleural space which compresses the lung. Pleural effusion, which is excess fluid accumulation in the pleural space. Empyema, a pus-filled infection in the pleural space, and for post-surgical drainage. The two main types of urinary catheters are retention balloon, or Foley, and the straight type. Urinary catheters are sized using the French system for sizing. 2.6 to 5.9 mm corresponds to 8 to 20 units in the French system. French, big F little r sizes for catheters are measured by the catheter's outer diameter. Saline solution is used in the balloon of a Foley catheter. A Foley catheter is used for various purposes such as bladder emptying, to relieve bladder retention, to irrigate the bladder, to relieve incontinence, and to introduce drugs into the bladder. Catheterization permits the accurate measurement of urine output. If the radiographer empties the urine collection bag, then urine output must be measured and recorded unless noted otherwise. Removing a urinary catheter is necessary when performing voiding cystourethograms. First, wash your hands, provide for patient privacy, and explain the procedure. Put on gloves. Uncover the patient and place a basin under the catheter valve, cut the tip of the balloon valve with scissors, and allow water to drain into basin. Once water flow has ceased, place towels under the catheter and pull gently, stopping and informing a physician or nurse if resistance is noted. Once removed, wrap the catheter in towels, cover the patient, then discard the catheter. With regard to intravenous and intra-arterial lines, sterile technique is required for the insertion of lines, catheters, into veins and arteries which are used for a variety of purposes. Venous and arterial lines require imaging to confirm placement and functionality. Technologists must remain aware of lines, their equipment, and their positioning. Permanent pacemakers are electromechanical devices inserted under the patient's skin to regulate the heart rate. Pacemaker units are approximately 1 inch in width, in diameter, and in thickness and weigh a little over 1 ounce. The role of the radiographer is to operate the fluoroscopy unit, which will allow the physician to place the guide wire and pacemaker assembly correctly. Newer pacemaker designs are MRI compatible. In portable and surgical radiography, pay strict attention to sterile technique. Be aware of the sterile corridor and respect its dimensions. Portable fluoroscopy requires that the image receptor and patient be draped. C-arms are commonly used in surgery to perform fluoroscopic surgical procedures, but adequate working space is typically a problem. Newer DR detectors are gaining popularity in surgery. The surgical draping of the C-arm and the patient is performed by the surgical team. C-arm draping may use any of 3 methods: a snap cover bag over the image receptor, a shower curtain drape, or, less commonly, a barrier placed over the surgery site during imaging. When taking radiographs in the operating room, dress appropriately, be aware of the sterile area, identify members of the surgical team and float nurse, take charge of your area of responsibility, position the image receptor and X-ray unit appropriately, and communicate clearly with operating room staff. Neonatal portable radiography is typically performed on very high-risk infants. Extra care is required to ensure aseptic techniques. Imaging is often performed for transient tachypnea of the newborn, TTN, or respiratory distress syndrome, RDS. In neonatal portable radiography, cross-infection is to be avoided, and gonadal protection is very important. In all portable radiography, patient movement must be, if possible, minimized. Every precaution must be taken to ensure the safety of the patient and healthcare worker. Adhere to proper protection protocols. Follow recommended good practices for the removal of hazardous waste.